share my screen. Just give me 1 second. Share screen. I think I need to be made host, Rafa.
I got it.
Or co-host. Let's see. Still can't share screen.
There you are. Okay, I should be good to go.
Okay, so I can share my screen. Can you all see the screen?
Yeah.
Awesome. So I'll also be, I'll scribe as well. Okay.
Don't worry, I'll go slow and I can help you if you need.
Perfect. No problem.
If you have any gaps. So this is a 84-year-old man that presents with dyspnea and jaundice.
Okay. Shall I go first, or Zaman, did you want to jump in?
Go ahead, please.
Okay, so we have a 84-year-old man with dyspnea and jaundice. So those are two very broad chief concerns. So I think with both of these, I'm trying to figure out which one I should focus on and which one will help lead me to a more specific, or kind of will lead me to will have a narrower differential. So for jaundice, I'm converting that in my mind to hyperbilirubinemia. And we can, kind of the first branch point we can use there is this prehepatic, intrahepatic, or posthepatic causes. So that would be the first branch point I'm using. When we're layering on dyspnea, that has its own set of a differential, anything from primary pulmonary causes to renal causes to hematologic causes. So the overlap there is really interesting. I think one thing that's just immediately jumping to my mind is oftentimes with a primary liver pathology, you can get ascites, and with that, that can be compressing on the diaphragm, leading to dyspnea. So that's just kind of an initial overlap that's jumping to my mind. But some important things I want to know is the time course and kind of how long this has been going on. So those are my initial thoughts.
That was beautiful. Love the kind of starting with a systematic framework for jaundice, and then some of the patterns that both you and a couple of people in the chat are already potentially putting together. And Abdulaziz also volunteered to help us, Madalena. So love to hear if he has any other ideas or if he wants to hear more and take on the next aliquot.
Yeah, I'd like to hear more of the case.
Okay, let's do it.
Okay, so this patient over the last 4 weeks endorsed dyspnea after walking 700 feet. At baseline, he cycles up to 100 miles per week. This patient also noticed the yellowing of his skin 3 weeks ago. And he reports bilateral leg edema for 2 weeks. Review of systems, no subjective fevers, no chest pain, no PNG, no orthopnea, bleeding, abdominal pain, rash. All of those were negative. I'm gonna give you a little bit more of the past medical history of this patient. 19 years ago, he had a cabbage, CABG. 5 years ago, he had a surgical aortic valve replacement. So he had a cabbage 19 years ago and the aortic valve replacement 5 years ago. This patient also has atrial fibrillation. He's currently on anticoagulation, and he has heart failure with reserved ejection fraction. His medications include atorvastatin, 20 milligrams, furosemide, 40 milligrams, ramipril, 2.5 milligrams, and finally, rivaroxaban, 20 milligrams. And that's the end of the aliquot.
Okay, Abdulaziz, did you want to share your thoughts?
Yeah, so the patient have exertional dyspnea and jaundice. This I think about prehepatic cause like anemia and hemolytic anemia. That patient can present with signs of anemia like exertional dyspnea, lower limb edema, and the patient become jaundice. So prehepatic cause is top in a differential for this patient. Based on the patient have aortic valve replacement, that aortic valve had the ability to destroy the RBCs and formation like hemolytic anemia. So aortic valve replacement cause of hemolytic anemia. This can be the cause of hemolytic anemia for this patient and the jaundice. So this is my thought now.
Yeah, I think that's a great thought. I think focusing on the aortic valve replacement and that potentially causing hemolytic anemia from kind of mechanical shearing, that's definitely something that jumped out to me as well. And if we, there is kind of a lot of information that we got here. So I like to build a problem representation just because it's easier for me to kind of keep track of everything. So the problem representation is the who, the what, and the when. So in terms of kind of the who, what's really stood out to me is that he's an 84-year-old gentleman, but he cycles 200 miles per week, which is quite a lot. So it seems like at baseline, there's a good amount of activity, even despite this kind of significant past medical history. So going back to the problem representation, I would say this is a 84-year-old man with a history of heart failure, CABG, status post aortic valve replacement, presenting with a subacute 4-week history of dyspnea, jaundice, and leg edema. So that kind of helps me just kind of summarize all the information into and kind of picking out the pertinent things to focus on. So yeah, Abdulaziz, I really liked what you said about kind of hemolysis potentially causing both the jaundice and the shortness of breath. What else here? The bilateral leg edema, that potentially could be from, if you're having, liver failure and have low albumin, that can cause kind of a low oncotic pressure and leading to bilateral leg edema, or it could be from increased hydrostatic pressure from potentially the heart failure. So those are some of the things I'm thinking about. And I think on the exam, if I want to look to see other signs of cirrhosis, so either signs of portal hypertension or high estrogen, those are some things I would be looking out for.
Even the lower limb edema may be due to exacerbation of heart failure by the anemia itself. So maybe that is exacerbation by the anemia. Even the anemia can do hypot heart failure. They present like any heart failure with lower limb edema itself.
Yeah, that's a really great point. Oh, Zavin, I think you're muted, but I see your mouth moving.
Thank you for noticing. I wanted to ask y'all and everybody, tuned in, if this is heart failure, getting worse, how could that connect with the jaundice?
Can you repeat the question?
I was wondering if y'all have any ideas of, okay, so let me take a step back. I think the reason the dyspnea and jaundice is kind of a cool combination of presenting symptoms, right? That foreground is that, both are common. Certainly dyspnea obviously is not only extremely common, but has a very broad potential, right? And jaundice, we also like working up because it's, we have a good framework, and often it's something significant. And but the two coming together, right? I got the feeling that a lot of people's minds tended to sort of like go after the jaundice first. And the reason is that it seemed, in the context of dyspnea, it seems very, and with the concurrent onset, right? It seems very like it could be a discerning feature. Like if you think about all of the pulmonary causes of shortness of breath, for example, few of them connect with jaundice, right? So immediately the jaundice helps to filter out this huge subcategory of causes of shortness of breath. People thought of hemolysis, people thought of cirrhosis, and the ways in which cirrhosis could cause dyspnea. That was perfect. But I think if I were to like, think about the most common causes of severe dyspnea, at least in the hospital setting for me, and like mild bilirubinemia, it's actually heart failure, with heart failure causing some hepatic dysfunction via congestive hepatopathy. That can happen both, people talk about like shock liver injury in a setting of low cardiac output, but even more frequently, there's liver injury in the setting of elevated, right-sided venous pressures. And that can present with both ALT/AST abnormalities and certainly, some degree of hepatic dysfunction with jaundice, even slight elevation in INR, things like that. So, that was kind of the foreground. And then when we heard the background of him having, a lot of cardiac history, the AFib, the coronary disease, the valve, and now having this very marked drop in exertional capacity, it kind of like increases some gravity for this being, and the leg swelling, as sort of, I think, who was it? Syed in the chat kind of went after the current probability of his heart potentially being involved, either primarily or secondarily, has increased. Yeah. Okay, shall we round out the rest of the history, Rafa, and see how he looks?
Sure. Okay, so I'm gonna give you the physical exam now. His temperature was 36.4. Respiratory rate 15. His blood pressure was 138/75. And this patient had a heart rate of 98. And he's saturating on 96% on room air. Generally speaking, this patient appears fatigued. He has a positive sclerotic ricturus, no lymphadenopathy. Respiratory exam revealed fine bibasilar crackles. The crackles are not cleared after coughing or changing positions. There is no wheezing and no bronchi. When it comes to the cardiovascular examination, presence of early blowing diastolic murmur. The JVP 6 centimeters above the sternal angle, JVP 6 centimeters, and no extra gallops, no S3, S4. When it comes to the GI, this patient has a soft, non-distended abdomen with bowel sounds present, no tender, no guarding, negative Murphy sign, and no hepatosplenomegaly. His skin is warm, dry, and there are no rashes. When it comes to the extremities, his extremities are warm to touch. 2+ pulses in upper and lower extremities. And 2+ pitting edema up to the knees bilaterally. When it comes to the neuro exam, it's pretty much unremarkable. And that's the end of the aliquot.
Abdulaziz, do you want to go first or second? What would you prefer?
I will go second if first.
Okay, sounds great. So, okay, so there's a lot of good things to discuss here. So the first thing I was, really anticipating were the vitals to see how stable or unstable is this patient to dictate, how quickly we need to act. And I was actually pretty reassured by the blood pressure and saturating 95% over Mayo, like not too hypoxic. So I was overall kind of reassured by the vitals, though I don't. I was additionally reassured, but I don't want to be too reassured in case something changes very fast. So the scleral icterus, that's something I was expecting given the jaundice that was reported in the HPI. The fatigue likely related to the dyspnea. So going to the cardiovascular exam, the early diastolic murmur, I initially thought of, could that be related to the aortic valve replacement? Could that potentially be aortic regurgitation? Something that I would want to know is there some malfunction with the valve that's kind of causing this subacute presentation of dyspnea and jaundice, or has that been present for a longer period of time? And that's kind of related to the fine bibasilar crackles. So if we go with the thinking that maybe there's an issue with the valve causing aortic regurgitation and back up into the lungs, that could potentially explain the crackles, though I think we would expect kind of some extra heart sounds like an S3 for volume overload if that were the case. So that's what I was thinking about the diastolic murmur and the crackles. No distended abdomen, that also stood out to me because with a lot of causes of jaundice, I think about ascites and if portal hypertension is present or not. So that was the fact that there's no obvious ascites stood out to me. And let's see here. I think what would be really helpful from the labs is determining if this is direct or indirect bilirubin, which can be really helpful in narrowing our differential. But kind of a summary from the exam I'm taking away is that there's no clear signs of cirrhosis. So there's no signs to me of portal hypertension or high estrogen, which is one of the most common causes, and cirrhosis is one of the most common causes of jaundice. So we're not seeing that type of picture here. Abdulaziz, what do you think?
Okay, I think this patient by examinations have a symptom of sign of heart failure. There's a right GVB, basal carcass, lower limb edema. I think that's from the valvular dysfunction by early diastolic murmur that indicates maybe aortic regurgitation and valvular dysfunction. By this dysfunction, maybe lead as force sharing for RBCs, then patient become jaundice from the hemolysis of the RBC. So go this the same idea from the first point. So the patient maybe have aortic valve dysfunction, tearing for the RBCs and making the jaundice and exacerbation is symptom of heart failure.
I love it. I think hit it on the head. Both noting the absence of signs of liver disease, right? Supportive signs on physical exam, chronic liver disease at least, as well as the presence of kind of some signs of heart failure and valvular dysfunction specifically. And to answer the question of like, oh, should you expect to hear an S3 in everybody with volume overload? Not necessarily. It's a specific physical exam finding for heart failure in patients who present with dyspnea, but it's not necessarily very sensitive, and certainly depending on also the operator. But I would say that most patients that I take care of with heart failure, I don't necessarily hear an S3, even with my very fancy bell over here. Yeah, I think it could still be, what's going on. The valve, I'm worried about. I think this isn't the type of patient that you just kind of, treat medically and kind of optimize with diuretics and other things. Anytime you have, valvular dysfunction, especially one that's more acute, and especially one that is of a prosthetic valve, you need to have kind of definitive imaging of the valve and involvement of cardiology, because these valves, they dehiss from when they were sewed in, and the regurgitation could be happening there. The leaflets are, less healthy than native valves and stuff, so they can perforate, they can get complications that become essentially surgical diseases. And certainly in this patient who was like so fit and is so unfit now, this is a big change that happened, and it probably all has to do with that valve, based on kind of the physical findings and the data that we have so far. And then I think the theory still, Abdulaziz, of this being hemolysis related to the valve, completely possible. I think the liver dysfunction from heart dysfunction, still very much possible. And then the last possibility is that, what if this slight regurgitation is actually chronic? And the murmur is an incidental finding that would have also been present 3 months ago when this guy was, biking 100 miles a week. That's possible. And then the explanation of the symptoms is he could just have a new hemolysis and a hemoglobin of 5 from like some other process related to the valve or not. And this is now dyspnea and heart failure from, profound anemia. And that'll be an easy answer once we get the lab work, which we can hear about now.
Incredible discussion. Okay, so the sodium was 139, potassium 4.5, chloride 101, bicarb 26. His glucose was 113. His BUN was 37. Creatinine 1.2. His baseline was 1. And his calcium 8.9. Phosphate 3.6. And magnesium 2.2. I'm going to give you the CBC as well. The white blood count was 9.09. The hemoglobin was 8.5 with a MCV of 96. And his platelets were 392. His PT was 22.9 seconds. His INR was 2. And his PTT was 40.5 seconds. I'm going to also talk a little bit about the liver chemistries now. The total bilirubin was 3.4 with a direct bilirubin of 1.1. His ALT was 54, AST 46, ALK-Phos 70, albumin 3.5, and his total protein was 6.6. And there are do you want me to stop right now, or do you want that I give you additional workup?
I'm getting an X-ray and EKG or
Oh, okay. X-ray or EKG. Actually, the EKG, it's not revealed, but we have. Oh, sorry, that is. Oh, I almost spoiled the case. Sorry. So the EKG showed irregular rhythm, left X deviation, and also showed old septal infarcts. I don't know if I mentioned or not. Okay, so the pro-BNP was very elevated, 7,646. and his lipase was 6.68, sorry. I'm gonna give you just a little bit more about the blood workup. The haptoglobin was 7.7, which is low. The LDH was high, 625. And the TIBC was within normal limits, ferritin within normal limits. And both of his B12 and folate were elevated. And that's the end of the aliquot. The lipase was 68 and LDH was very elevated. Yes, the LDH was 625.
Okay. Abdulaziz, do you want to go for it?
Okay, I will go. So in sodium and potassium, so serum creatinine and electrolyte was the normal level, but if you see the hemoglobin is low, 8.5, and the patient have signs of hemolytic anemia. Base of heptoglobin is low, very low, and the LDH has very high. That indicates this patient was going hemolysis, and the bilirubin is merely indirected, so that's indicated that patient is going in hemolytic anemia more than everything. So the base of the anemia is hemolytic anemia, ferritin and B12 is normal. So the anemia and the jaundice is due to hemolytic anemia, and the patient heart failure because the patient have very high BNP level, so indicate this patient heart failure with hemolytic anemia. So I will waiting the echocardiography to see what's happening. Even if they have ability to peripheral blood picture to see the sharing and RBCs, that's very nice. Okay.
Yeah, I think that was so beautifully said. I basically have nothing to add. That's exactly where my mind was at. I think, we see a picture of a hemolytic anemia with a indirect hyperbilirubinemia, a low haptoglobin, high LDH, and I think signs of cardiac strain from the high BNP. And I totally agree that the next step I would want to do is an echocardiogram to assess valvular function. So I basically just summarized what you said. So I'm totally with you. I guess one other thing that stood out to me is the irregular rhythm on EKG. And we know that the patient has a history of AFib, but yeah, I guess I'm just a little bit concerned that he's currently in an irregular rhythm. So I would, I don't think that would change my management at this point. I think I would still just want to get an echo, but that just stood out to me.
This is the first
Yeah, I don't have too much more to add either. We're kind of reframing the case as hemolytic anemia with resultant likely exacerbation of the heart failure. And if the hapto is low, it specifically supports intravascular hemolysis, right? So a lot of hemolysis, including RBC abnormalities and immune hemolysis, is largely extravascular and can have a normal hapto, right? So when you see intravascular hemolysis, are there things that kind of you worry about more or want to make sure to rule out?
Unmute. So some other causes that come to mind for intravascular hemolysis are the MAHAs, so the microangiopathic hemolytic anemias. One time, I think it was from probably a CP Helpers podcast, I heard this, but someone framed hemolytic anemia as, is it a problem with the red blood cell itself or the red blood cell's environment, which I think is a kind of a really helpful way to think about it. And in this case, it's seeming like the red blood cell's environment is most likely the issue. I think our leading theory here is that potentially it's mechanical shearing from the valve, but other things I would think about are like MAHAs. Anything else you would think of, Abdulaziz?
Yeah, with you. I think about MAHA more than anything in hemolytic anemia.
I think the reason I kind of wanted to just highlight that is that microangiopathic hemolytic anemias and all of them have to do with the category of illness is called thrombotic microangiopathies, right? TTP, HUS, DIC, scleroderma renal crisis, antiphospholipid syndrome. Those are all really bad diseases, some of which have completely life-saving treatments, right? And somebody just added a level of specificity to the 392 platelets. Oh, you're just adding that as Marcella, 392,000. Thank you. But that was good timing because that's the thing that kind of like puts that aside, right? You have to have thrombocytopenia with thrombotic microangiopathies. And that's very reassuring that this patient doesn't have, and sort of shifts the differential strongly towards the valve potentially causing the intravascular hemolysis. The one thing, oh, never mind. I was going to say the INR being elevated, would make you think of DIC more strongly in this context, but the rivaroxaban can elevate your INR mildly like this, so that's probably what that's from. And then my other questions that I have in my mind for this patient is like, okay, what started the hemolysis, right? The valve, he wasn't hemolyzing presumably a month ago or a year ago. So did the valve change and that's why he's now hemolyzing? And how much of the heart failure is from the anemia, or how much of it is actually from the valve dysfunction? So I think that's still kind of an open question that needs answering. And then the other question is like, how severe is this hemolysis? He's quite anemic. It sounds like we don't have a baseline. And the LDH is pretty high. Something I would like in this patient is a reticulocyte count, because another possibility is that you can have more chronic hemolysis but compensate well if you have the folate and iron and a bone marrow. And sometimes when it actually presents with bad anemia is when you like run out. So I think if this patient's retics are elevated, it kind of would be a sign that maybe he's actually reacting and the hemolysis is more new and more severe, and also suggest a more kind of acute onset potentially.
And I guess
no, just gonna say the reticulocyte count is 3.55%, but they don't say if it's low or normal. So I don't know.
That's low for this level of anemia. So
and we also,
go ahead.
So sorry, go ahead.
No, please.
Oh, I was just gonna say, and I guess ask, we also want to get a peripheral smear in this case to look for signs of schistocytes and yeah.
Absolutely, that's a great idea. Part of the workup of hemolysis and schistocytes, but also other kind of signs of RBC abnormality, other signs that can support hemolytic anemia or immune hemolytic anemia, like spherocytes, like rouleauing, things like that. And then Coombs has been suggested as an important next step as well.
Okay, I'm actually gonna give you one more alipod before revealing the diagnosis. So I think echoing Madalena's thoughts about the elevated PT or an irregular rhythm, the team actually ordered a CT angio with contrast, and there was no evidence of pulmonary embolus. However, it showed bilateral ground glass change, as well as bilateral small pleural effusions. And also cardiomegaly. They did an right upper quadrant ultrasound that was pretty much unremarkable. And then they further had hemolysis workup. The peripheral smear showed poikilocytosis, anisocytosis, I'm so sorry if I'm butchering those words, and macrocytosis. But no spherocytes or no schistocytes. They did direct antibody testing, both, and they're negative for IgG and C3. And they also did a thin and thick blood smear that was negative. I have no idea what to do with this information. And about malaria and babesia were both negative as well. And that's the end of the article.
Okay. Yeah, to be honest, I'm a little bit stumped. So let's see, what information do we have here? So let's just kind of go through systematically, but I'm definitely going to need some information, some help from the chat. So I guess if we start with the CT angio, no evidence of PE, bilateral ground glass opacities, and pleural effusions. So my initial thought there is that the result of the heart failure picture that we're seeing, kind of with backup into the pulmonary system. And that would be kind of supported by the cardiomegaly we're seeing here. For the smear, we were discussing earlier the picture of this being hemolytic anemia, and specifically from potentially, mechanical shearing from the aortic valve. However, I would expect to see schistocytes in that case. So that makes me put that theory a little bit lower on the differential, but I'm not, maybe you could still have shearing but not have schistocytes. I'm not exactly sure there. Yeah, I'm a little bit stumped here, and would love to hear your thoughts, Abdulaziz.
Okay, I think if the patient has hemolytic anemia, it's all right to do malaria tests and babesia, because this both infectious has ability to intravascular hemolysis. So it's negative, even the smear was shows no signs like the of MAHA. So the ground glass appearance and pleural effusion, sometimes the pulmonary edema or lung congestion can present like ground glass appearance. If they have mild pulmonary edema, can present like ground glass appearance and pleural effusion. So I think I will need echocardiography to see what's happening to the heart, really, still.
Yeah, I think I'm with you on all of those counts. I think that if the echo shows that there's acute valvular dysfunction, even with the negative schistocytes, I would probably blame the valve most. Again, all of these tests have, are not perfect, right? And both in terms of the intrinsic test as well as our ability to actually, sort of detect the abnormalities, right? The sensitivity is less than 100%. So I wouldn't exclude intravascular hemolysis just because we didn't see schistocytes. I think it's still possible, although it reduces the likelihood. The one thing that we didn't talk about that is possible is some infections can involve dyspnea pulmonary manifestations and be associated with immune phenomena, including hemolysis. Mycoplasma is one. I don't know also if the direct antibody test necessarily, detects cold agglutinin disease, which might be worth testing for separately. But I think in most cases you would have a positive kind of antibody screen, and then you would subspecify with specific testing that it's cold agglutinins. But overall, it's not a good fit in this context. I think it's less likely. I think it's probably still the valve. If I had to guess, for an 84-year-old person to be presenting for the first time with, a red cell membrane defect, I think it would be unusual. And so that's less likely among, causes we haven't spent too much time talking about. And then the other cause of hemolysis, PNH, paroxysmal nocturnal hemoglobinuria, that often causes hemolysis or pancytopenia, but it's also one of the most prothrombotic causes that are out there. And anytime you have a prosthetic valve, it's not mechanical, but valve thrombosis and not just kind of deterioration is also a possibility and could lead to dysfunction. But I think that's just a rare disorder that we should have a lower pretest probability for. So I think that the big next step for me is the echo, and if that doesn't, if that's unremarkable, then we'll have a harder time kind of knowing where to go from here. Rafa, why don't you move us forward or take us home, I guess.
Okay, so this is the last study quote. The echo was normal. No, just kidding. The echo showed a left ventricular ejection fraction of 68% with moderate diastolic dysfunction and elevated left ventricle filling pressures. The aortic prosthetic leaflets appear thickened. There was no evidence of stenosis of the prosthetic aortic valve. However, this patient had a moderate to severe aortic insufficiency that was worsened compared to a prior echocardiogram. He also had severely elevated pulmonary artery systolic pressure. And that's the end of the case. Oh, of course, I will read the diagnosis later.
Okay, so from this information, what's really standing out to me is, I think you said moderate to severe aortic regurgitation. Is that right, Rafa? Okay, so to me, this is really screaming that there's an issue with the aortic valve replacement, and potentially from the mechanical shearing that's leading to this indirect hyperbilirubinemia and jaundice, and causing the shortness of breath. So from this, I'm really kind of at the top of my differential is valvular dysfunction leading to the shortness of breath and jaundice. Yeah, and I think that can explain kind of the elevated left ventricular filling pressures as well. What do you think, Abdulaziz?
Really, totally agree with you, Madeleine.
Same.
Okay, that's our diagnosis, Rafa.
Okay, so this patient was eventually diagnosed with hemolytic anemia. He had a bioprosthetic aortic valve degeneration with predominantly transvalvular aortic regurgitation causing the hemolytic anemia. The patient had a coronary arteriogram and showed patent grafts and no other significant obstructive disease. And to fix his bioprosthetic valve, he underwent a valve-in-valve transcatheter aortic valve replacement. After this procedure, his jaundice and shortness of breath resolved. And on a subsequent TEE, there was no aortic insufficiency on the arteriogram, and also showed a significant improvement in his condition overall. And that's the end of the case.
Great case.
That's everybody. Yes. Oh, go ahead, Madalena.
Oh, I was just going to say, Rafa, thank you for presenting this case. I think let's see, I'm trying to think of my kind of reflections here. I think it can sometimes feel intimidating when you have these chief concerns that are so broad, shortness of breath and jaundice can lead to so many different things. So it was really helpful to Abdulaziz and Zaman to discuss with you kind of a more of a structured approach to both of those. And I think another thing that I'm taking away is how tests are not perfect. And, in my mind, I think whenever you have, especially in hemolytic anemia due to mechanical shearing, I so assumed that you would see schistocytes on a peripheral smear, but these tests aren't perfect, and you don't have, you really have to think about the sensitivity and specificity of these things. So, but I just found it very helpful to kind of walk through these very huge chief concerns in a structured approach, and it was just so much fun. So I learned a lot.
Yeah, very nice case to discussion, and the way to bring from the chief complaint, the analysis, the histopathologic illness, the imaging, the physical examination was very nice. Really, I enjoyed this case.
This was so much
And
fun.
thank you.
I love discussing with you, Abdulaziz and Madalena. Thank you everybody for joining. Are we gonna summarize the teaching points, Yasmin?
Yes, so amazing case, by the way. Our teaching point is jaundice. We can start by defining it if it's prehepatic, hepatocellular, or cholestatic. If it's an increased bilirubin production, this is that impaired hepatocyte function production, or obstruction of the biliary system. We also can, from the beginning, we had hemolysis as a cause for this case, and it's because of prehepatic jaundice. It can be due to RBCs, structural defects, autoimmune hemolytic anemia, or hemolytic transfusion reactions. We also know that now that congestive cardiomyopathy can be suspected in patients with right-sided heart failure, and it presents with jaundice and tender hepatomegaly. There is, in this patient, we also saw a high jugular venous pressure that also appears in heart failure, fluid overload, tricuspid valve dysfunction, and so this provides us with information about fluid status and cardiac function. Now, the irregular rhythm, for us, we also have to think about atrial fibrillation. The literature also mentions about wandering atrial pacemaker or multifocal atrial fibrillation, although atrial fibrillation should be our first thought. Now, the haptoglobin and LDH are markers helpful in this case. The haptoglobin was low, which is highly specific for hemolysis, although it cannot be used to determine if it's extravascular or intravascular. A high LDH indicated cell injury, which could be due to cancer, hemolytic anemia, myocardial infarction, infection, etc. And our final diagnosis of hemolytic anemia presents with pallor, fatigue, exertional dyspnea, jaundice, splenomegaly, and also it can have the low haptoglobin, high LDH, which is what we saw in this patient. And there are different etiologies, specifically microangiopathic and macroangiopathic hemolytic anemia. And that's it.
Beautiful.
Yasmin, those are such amazing teaching points. Thank you.
Thank you. It was so interesting, this case.
That
Agreed.
was really fun. Thanks, everybody. Hope you have a great day.